Thank you, Dr. Adnan. So in the interest of time, we'll move on with NICVD, and Dr. Jahangir is going to present the NICVD program and data from there.
Thank you very much. Slide. So today I'm going to present NICVD data. The past 1 year, we have done more than 100 cases in a year. So we will just go through that cases, and I will share you the results of mechanical thrombectomy that we have done at our NICVD Karachi center. So there's a 1 year experience of newly established stroke service, a single center data. This is all about the NICVD. This slide shows NICVD as a complete. You can see the red bar, that is the NICVD. Center is the main NICVD, and other the periphery. You can see the satellite center. They are doing 24/7 free of cost services to the patient. And the green bar shows there is a unique service, our unique service, that is the chest pain unit. There are 24 chest pain units we are running in our Sindh province. And our plan is to start the stroke in our few satellite centers that we start with from the Sakhar and Tandu Muhammad Khan in next 6 months. This is the data which we have done. In last 1 year, more than 2.2 million cases I've seen in the NICVD Karachi Satellite Center and the chest pain unit. These are the numbers. You can see angioplasty, angiographies, and open heart surgery and TAVI, in which we have done 102 cases of the stroke intervention. So how we will proceed? We have a stroke team that is included 9 members, in which 7 are the intervention cardiologists, 1 is the intervention radiologist, along with a neurologist. We have a 24/7. There's a dedicated doctors available in emergency department who initially assessed the patient and decided to proceed for the further intervention. Whenever the patient present in the emergency department, our doctor will see the patient. As this data, in last 1 year, we have received 1,400 stroke patients, in which 1/3 of the patient, they are straight away referred to the neurological center because of they presented, most of the patients, they presented very late, after 24-48 hours, in which 925 patients was selected for the CT scan brain. Okay, thank you. So 925 patients was selected for CT scan brain, in which 386 patients, they shown the hemorrhagic complication. The international data shows the hemorrhagic presentation is about 15%, but what we have found 30% of the patients, they develop hemorrhagic. There are multiple reasons in that we have to go through to see why we have found more large hemorrhagic complication. After that, we exclude the hemorrhage, further proceed for the contrast. So giving contrast, we assess the aspect score in the CT department. If patient have a good aspect score, we proceed this patient for the CT we give the dye and to see if there is involvement of the large vessel or small vessel occlusion. We have found 90 patients who have a small vessel occlusion, in which only 18 patients, they came into the TPA window. Then we given TPA in these patients, but out of that, we have a 150 patients, they turn out to be a large vessel occlusion, and 102 patients was qualified for the mechanical thrombectomy. Or initially, we have given TPA as a bridge therapy. Initially, we have given 9 patients with TPA along with mechanical thrombectomy. So this is the first class 1 indication of mechanical thrombectomy. This was the inclusion criteria. I don't want to go in detail. So we have started stroke in the late of 2021. We started slowly. This is the monthly distribution of the patient who presented to the emergency department, and these are the mechanical thrombectomy. We start slow. In the end, we have done 16 cases in the Jan. This is the age distribution. Predominantly was the male, but look at the median age in this slide. You can see the median age is 52. 27% of the patients, they are young, 20 to 45 years. And these are the risk factor. Around 50% of the patient was hypertensive, 21% of the patient was diabetic. Smokers are there in 12%, and 22.5% patient having a atrial fibrillation, around 22% patient having a low ejection fraction. 4% of the patient, they have a prior stroke. Around 9% of the patient, they were on warfarin because of the multiple reasons. And one patient have a prior history of PTMC. This was the valvular heart disease. We found 20% of our stroke patients who have a valvular heart disease, but predominantly they have a severe mitral stenosis. 11% of the patient having a severe mitral stenosis. Other have a patient having a history of MBR, AVR, severe MR, and severe AS, and severe AR. I don't want to go to this aspect score for the MCA, but what we have found in our patient, their median NI score was initially 18%, at discharge was 12, and in follow-up was 4. The median MRS was at discharge was 4, and follow-up was 3. Aspect score was 10, and 25% of the patient we found they have a good correlators on CT angiogram. 43% patient they presented with the right-sided weakness, and 57% of the patient they have a left-sided weakness. This was the anatomical distribution of the patient who presented here. More than 70% patient have a occluded MCA, the anterior circulation MCA occlusion, and 27% patient having a ICA occlusion, in which 19% have a ICA terminus and 8% have a proximal ICA occlusion. We found 2% of the patient they present with posterior circulation stroke, there was an occluded basilar artery. The technique we have used, that is the adopt and the Solumbra technique. Mostly we have done the adopt, in which we don't use the stent retrieval. So we just do aspiration to remove the clot that is present in the cerebral vessel. So I don't want to go in detail between two techniques, adopt and Solumbra. Its only difference is that in adopt technique, no need to use the stent retrieval. In adopt, in Solumbra, you have to use the stent retrieval along with the aspiration.
Jahangir, last 30 seconds, please.
Okay, sir.
Thank you.
So what we have achieved, the presentation, 74% of the patient have a TICI zero flow, and we have angiographically success was 84%. The median passes of our patient was the 3 to 4. This was the complication we have seen in our patient. Lot of patients, they develop aspiration pneumonia. And this is the procedure complication. We have found symptomatic hemorrhage in 13% of the patient, although it was little bit high in the international data, but because of the initial stages, we use TPA, and we found more bleed in those patients in which we gave TPA as a bridge therapy. So 11 patients have a malignant complication, malignant infarct. The survival rate was 73%, and the mortal expiry was 27%. So this was the mechanical thrombectomy, the 85% angiographic success. We found TICI2B3 flow, in which our patient was discharged successfully, 79% of the patient, and 21% expired, but 49% of the patient back to his normal life. And along with 51% of the patient, they show partial improvement initially, but later on in follow phases, they improve their quality of life. So those patients who were angiographically unsuccessful, those less than TICI2A results, 53% patient was expired, but 47% of the patient, they were discharged with clinical improvement. This was the 49% of the patient back to normal life with MRA score 0 to 1 out of angiographical success patient. We have found 52% of these successful patients, the immediate result, within 48 hours the patient, they improve, and they improve within 48 hours. And those patients who are expired was 26%. In which the procedure complication, bleeding, malignant infarct, and medical complications such as aspiration, pneumonia, cardiac complication, found in these patients. So what the global figure of the functional intermittence shows, Mr. Killeen shows there the 32% of the patient have a functional intermittence, and the down trial shows the 49% of the patient, you've seen the MRS improve in 90 days as compared to the control group. This is the data, and you can see the all-cause mortality in Mr. Killeen 30%, and the Revascade shows 23% of the patient have a all-cause mortality. And the summary of NICVD stroke, we did a 102 patient up to the January, and we gave TPA in 18%. We have a functional independence is 49%, and the mortality is 27%. We have overviewed the mortality and the possible reason for high mortality in early phase because of initial phase of learning curve. We have a selection of patient was not educated in initial phase of our cases, the delay because of the presentation, imaging, and intervention, the lack of suitable inventory, and inadequate post-procedure care due to lack of training and health care. So, still, apart from, we should not forget the estimated worldwide 30-day mortality after first ischemic stroke range around 16 to 23%. But our later half, we have mortality is 23%, that is equivalent to the international data. So we are giving 24/7 services for mechanical thrombectomy. It is service for everyone. It's totally free of cost. We are working in a collaboration with technical support from our colleagues in the USA. We are also very thankful to the RIC. Initially they have support a lot. Overall, the outcome in our achieving functional intermittence is 49%. And our outcome was improved in later half, as we have done a lot of cases after that. So this is my last slide. This is a very famous slide that shows the intervention, the training of experienced intervention cardiologists can be short for 2 to 3 months. They can do mechanical thrombectomy. Thank you very much.
Thank you very much, Dr. Jahangir.